and share ideas. So the first part of it, that is actually on Facebook Live, so I just want to say hello to Facebook Live, but also to let everybody know in the room that this first part of the presentation, that is on Facebook. Once we are together and interacting, we will be off Facebook because we want to encourage everyone to be comfortable and candid in their comments. Okay? So before I get to the presentation itself, I wanted to show something that I consider, it's only 2 minutes, but really positive and really uplifting. Because when we talk about this population, it is very easy, obviously, to feel not only negative about it, but sometimes a sense of hopelessness. And this group is a national group that has been collecting information about models all over the country. So I wanted to tell you this as a resource and direct you there. So, Denise, what do I do? Just click to start, right?
Yeah.
Okay.
Welcome to the Autism Housing Network, a project of the Madison House Autism Foundation. The network has been created to be able to bring together partnerships in local communities. Let me walk you through some of the functions you can find here on our website. Make sure you take a look at the housing directory. You can view it either in the map view or as a list. Don't forget to use the filter for a more specific search. If you know of a project that should be in this directory, please submit it. Or maybe you're starting a project with some local families. Please submit those that are also emerging. Another element of the Autism Housing Network is the resource directory. The resource directory was created to be able to capture all the greatest resources that are out there in one place. You can also filter the resources for a more specific selection. If we're missing a resource that you've used and really value, please submit the resource to be added to the directory. Additionally, the housing directory and the resource directory have the opportunity for you to create your personalized toolbox. Just log into your account, favorite the resources that you think are best, and then see all of the resources and listings that you have favorited. If you have a question or want to connect with others, make sure you participate in the forums. The forums are where we can discuss best practices and solutions to barriers that all of us may face when trying to either create or find housing opportunities. If you haven't already, you should also consider looking at the Our Stories section. Hear straight from those who live and work in an array of different housing opportunities all across the country. If you think we're missing some content or would like to be a guest contributor, please contact us. We'd love to hear your feedback. Thank you so much for being part of this network. I hope to see you soon in the forum.
Can you bring my PowerPoint? So that is Desiree Kamika, who is been part of Madison House Foundation and the Coalition for Community Choice. She is an amazing resource. She has visited programs all over the country, and she is one of the most knowledgeable persons I've encountered on the national front in terms of understanding the Medicaid rules, and particularly in housing, not only what you can and can't do, but also to talk about what's happening across the country. She actually had a really big role in New Jersey. So when we had our first statewide transition plan, which was basically reporting to the federal government what we were going to have as a housing plan, when she saw our first version, which now we're on the fourth one and we're happier with it, but when we saw the first one, which was so restrictive because it said no farmsteads, no clusters, nothing but 25% of an apartment building, nothing other than group homes bigger than 4, not even houses next to each other, she actually came to New Jersey and spoke at Rutgers and talked us through, did an entire workshop. So they are a great resource, and particularly for these really exciting ideas that are happening out there. So this is the organization that she is involved with. It's the Coalition for Community Choice, and there's a second one that's recently formed, Together for Choice. And what really, I would say the common thread with these two organizations is that their mantra, the core of their beliefs, was that one size doesn't fit all. So that really advocating that, particularly for people with complex needs, either challenging behaviors or complex medical needs, that we really need an array of services. and these really have been the two leading forces. They're both free to join, so I urge you to join because they're really a wonderful resource. And at the national level, they are still doing very important work at the federal level to make sure that all these projects that are coming up are going to get approved. So I want to talk about this population in particular. So individuals with challenging behavior. I'm sure I don't have to tell anyone here in this group what researchers have found, because many of us have experienced this, that families whose loved one have complex needs, they experience isolation, exhaustion, safety concerns, and honestly, the real fear of injury and death. And that is the story that is not being told, right? Whenever we see news pieces or not just the fundraisers, but sometimes just stories that are out there, we always hear the positive, and not that we don't want to hear the wonderful outcomes, but this subpopulation really does sometimes face serious injury or death of the person or of family members. Good news, bad news, right? So the bad news, when we get together and work together in terms of what we need, I think we'll probably have a longer list than we even have time to get to. So we all know that we have a lot of work to do in New Jersey. But the good news is we actually do have a good statewide transition plan that allows for a variety of choices. So that is a very positive development. The other issue is that the big change that happened in New Jersey is that before fee-for-service, and everyone that's in the adult system, we're all holding our heads and pulling our hair out because we're still feeling around in the dark. So it's a new system, but there is one really positive change, is that in the old system, the range was sort of like this. So for residential and a day program and adult services, it's about $120,000 to $180,000. So that was sort of it. Under the new system, the range is now huge. 19,000 to 406. That's the highest rate. Those are cases that have acuity ratings, and that presents an opportunity. Now, we've actually heard of providers now chasing people that have the acuity rating. So in the past, when you would describe someone's behavior, providers would say, no, we don't serve that. We're actually experienced where when we hear from programs or someone gets on the waiver and we're talking to programs, they ask, what is it? You say they're a DA or an EA, and they say, we'll take them. And we say, well, let's meet them first, right? So we do have dollars to work with, but the key is that we've got to make sure that the dollars are spent on the individual, because for providers, you don't have to show dollar for dollar. So there is, and remember, some people that are getting this, that we're getting 120, they're in a very different crisis and a very real, significant crisis as well. So some of the older, larger agencies are really trying to figure out how to continue to serve who they're serving. But as a family, if you do have a family member that has one of the larger acute budgets, make sure that you are in your plan really itemize and documenting what the person is getting in terms of a service, all the way down to what their staffing ratio is when they're doing this versus that activity. Oh, what did I just do? Oh, Denise. Okay, so the key questions, right? So tonight is called, she knows she should not leave me with technology, right?
With the other technology.
Right. So the title of tonight is Key Questions to Ask When Selecting or Creating, right? Because there's a lot really percolating out there in terms of ideas. Sure. We're going to talk a little bit about the role of behavior analysts and the importance for database programming. But before we do that, let me just say one thing. What I'm about to share with you is no way, shape, or form based on science, okay? That's my disclaimer. It has just grown out of years of working with families when their children were going to residential, child or young adults, and thinking about the kind of things that they should be asking. It's based on good experiences that I've seen in other states, and based on really bad experiences, which we've seen all too often. I actually, when I first did this, I was on my way out to California to see a program, so on my way out and the way back, I wrote 120 questions and realized that that's way too long. So this is the condensed version. Okay. So if you have a person with challenging behavior, it's very important to have a BCBA, a board certified behavior analyst on the case. And one of the problems that we're seeing is that there has been an explosion of BCBAs. It's somewhat of a new certification because of also the insurance mandate where there is funding for it. We see many graduate programs opening up more and more, so there is a demand. But when you're looking at a program, you need to ask a couple of key questions, right? One is, what is the experience of the person? And more importantly, how many people are they responsible for? Because there is a concern that BCBAs might be involved, but they're literally sitting at their desk and reading a plan. They're not really getting in the weeds with the person. The licensing group that license BCBAs, they don't say a particular caseload, so no one's saying 10 versus 100, but they do have, there are an ethical code that people, if it stands in the way for practicing in the manner that you should to be effective, then in maybe one case, it might be 20 cases, but in other cases, it could be 2 cases. The term behavior analyst. So this we see a lot too, because families, particularly families coming up through school districts that have had behavior analysts in their lives, are finding in adult services, many providers are saying, oh, we have a behaviorist. So it could be a behavior specialist, a behaviorist specialist, a specialist specialist. We've heard all sorts of things. So just really make sure that you're asking that the person actually is a board certified behavior analyst that not only has the training, has passed the test, has the supervision, but has experience for individuals with challenging behavior. So these are some questions when you're looking at, I had a family recently that was referred for had just gotten on the waiver and went on a tour, on a meet and greet, on a program, and they said, yes, we serve people with challenging behaviors. This person was an EA, which is $406,000, and the parent said, can I meet your behavior analyst? And they said, oh, we just put the ad out yesterday. Okay, so we want to make sure that it's part of the program. Some of these questions, how many cases is the BCBA responsible for? How many hours a month is the BCBA spent directly observing or working and teaching the person, right? So in order to effectuate change, you can't just write a written plan. You've got to get out there. You've got to work directly with the person served. So that is a really important question. Directly observing, directly working with them. This one seems almost like a ridiculous question, right? For residential programs, do they actually spend time in the home where the person served is present? There are many programs where they're actually not even in the home. So you can't obviously be making sure that you have fidelity in your programs or that the staff is implementing the plan as written unless you're actually out there. Does the BCBA coordinate and share information with the day program? We see this a lot, particularly when there's 2 providers that they're not talking to each other. So make sure that you ask and that there's a system in place. The information that they're sharing, are families in the loop too? Again, sounds somewhat of a basic question, but we find in adult services that this does tend to drop off. Assessments. So there are many different assessment tools that professionals use. When you have an individual with challenging behavior, it often calls for a functional behavior assessment. This is a very loose term, okay? And we see this in school district cases too, where they have said they've done an assessment, but it's really not an actual assessment. That requires direct observation, taking data, looking at what the antecedent is, and trying to figure out what the function of the behavior is. Does the program allow outside consultants? Okay. Lots of families get into a program afterwards and have someone that's been working with their child for years, and now they're in a residential program and the person is no longer allowed to access it. That to me, is the hallmark of a quality program, right? Because that's about collaboration. And my experience has been programs that are of the higher quality, they generally welcome that collaboration and the input. When they're gonna do assessments, how long is it gonna take to be provided? I mean, I've been on IHPs where we're coming a year later. And, oh yeah, last year we did talk about doing that assessment, so we wanna ask that up front. Is the family gonna get a copy of the report? For those of you that are in school districts, you probably sort of can't even believe we're posing some of these questions, but we do often see this in adult services where there is paperwork that's created, but the family is not involved or shared. Applied behavior analysis is not just about challenging behaviors. In fact, to do it properly, efficiently, and honestly ethically, you have to also have a skill acquisition component to it. It's very important when you determine the function of behavior to be offering some programming for skill acquisition as well. So assessments are not only to look at the function of behavior, but also there are many assessment tools that can look at someone's skill set and identify what you need to work on next. Another assessment that's often used is preference assessments. That is often overlooked. So there are a number of tools out there, and I think it's just a matter of educating families so they know what the terminology is and they know to ask for it. How frequently are these assessments conducted? Because we have this in every system, but again, I think in adult services we see it all too common that goals just repeat over and over and over again. So assessments are not only to look at challenging behavior again, but you have to look at skill acquisition and replacement skills. Tracking progress. So if you take data and no one looks at it, then you should just write it on a napkin and put it up on a bulletin board at McDonald's, right? Because it has no use unless we're actually doing something. And we have to really watch out where data is just being recorded, but it's never reviewed by a clinician. So ask those questions. How frequently is it reviewed? Is the data graphed? Which is sort of a basic tenet of looking at behaviors, but many programs don't graph. And what's the role of the clinician? Same sort of theme that we just touched on slide before. How are we sharing this information with families, right? Families need to know. And families need to know not just because these are our loved ones and we want to know what's happening, but families are a wealth of information. We are the one that have been through the journey at every step of the way. So knowing what has worked, what hasn't worked, what you've tried in the past is critical. And also, you're spending time with your loved one. So you have to be part of the team. Okay. How many skill acquisition programs are run? What's the criteria for mastery? And more importantly, what's the criteria to modify or replace the goal? So again, we will often see either these very broad goals, like Johnny will be successful in the community. What exactly does that mean? We want to be more specific. How about Johnny will go to Wawa and get his own soda and insert the straw? That's the kind of detail that we're looking for. But we want to know how long is a goal going to run before you decide that it needs to either be changed, tweaked, or possibly abandoned, right? IOA data, not every program takes it. That, I always get this wrong. Someone's going to correct me. Inter-observer? Agreement? Okay, thank you. So that's where someone is taking data and another person comes and takes data at the same time and then they compare it, because we often have different definitions. So someone may be saying, oh, he's doing this independently. And then the other person comes along and says, well, hold on a second. No, you're not. You're pointing. You're saying something. You're touching his elbow. So having that second set of eyes is really helpful. Are there written progress reports? Are they shared with the family? And how often are they? Program monitoring. So I mentioned about outside consultants. So outside consultants can come in a variety of different forms. One is where you have a professional in your loved one's life and you want them to come in and be part of the team, or to come in and do an independent assessment. But this is another role that I think is, it sort of separates the A team from the B team. Programs that bring in independent consultants to do a program-wide review. So that's a question to ask, and if they do it, do parents get to see the results? Video monitoring. Okay. So I think that one of the points for tonight's discussion is that when we're talking about some of these things to ask about, we can look at it and approach it in a couple different ways. One of them is that in most circumstances, you can ask the question, and agencies will ask the question, and those of you that are out there dreaming and creating agencies should be thinking about this. And that's to ask the question of, what must we do, right? So that's one level. There's some things that you absolutely must do for licensing, right? What can we do? Because there are some things they don't have to do, but you are permitted to do it. And then the other thing is, what should we do? And the what should we do is what I think, as families that are looking at creating programs or improving programs or tweaking programs or starting programs within larger programs, that issue of not just what we have to do for the bare minimum, but what should we be doing? And the what can you do? I think this is probably the best example. We have a statewide family advisory council that meets each month with DPD, and one of the issues that came up in our last meeting was how there's many circumstances where providers will tell families that they can't do something because the state won't do them. This is the most common one that I see, the issue about, can you use video cameras? And the answer is, in New Jersey, it's different among states, yes, you can. You can use video cameras. You can use ones that record. You can use ones that are live. You can even have ones in bedrooms, not just common areas. Now, there are requirements that you have to go up through. You have to have a human rights committee involved. There has to be a process and procedure. You have to show a clinical justification, but you absolutely can. And, there's a program I saw in Pennsylvania called the Parles program, which has done some of the most amazing things I've seen with respect to technology, that not only that you can take a look in terms of what's happening in the home in the day program, but the behavior analysts can literally get it right there live in real time. So if they get alert that something has gone awry, they can look, they can talk to the staff. There's also a program out in Kansas, University of Kansas was involved, CLO, that has a sort of a monitoring station in each home, and a home base where the clinician sits and on shifts watches each screen. As there's movement, the screen moves to the middle. They can talk to the staff, and the staff can talk to them. The staff can say, hey, I think we're going to need a little extra help here. Or the clinician can weigh in and say, looks like Johnny's starting to be a little agitated. I think you should go over there and take a look. We've also seen it used for people not with challenging behaviors, but just as smart home technology to assist people. Recently, when a clinician was telling me she was looking in on one of the clients, and he was very independent, but she did check in periodically when he was cooking, and he put the newspaper down on the stove. So for her to see that, and he did have the skills that if she explained it to him and put it on the checklist of things to check. So it's a very important tool. And I think, when I was actually out in Kansas, I asked some of the staff members what they thought about this, because this was really like, you were monitored all the time. They all had phones. When they come in, they would swipe so you would know what time the person came in. For the medically fragile home, they had motion detectors, so for people that needed to be periodically turned, they would actually be able to show that, when the person was turned. So I asked the staff, how do you feel working? And they said in the beginning, they were terrified. And they thought, oh, this is Big Brother. But once they realized it was used for support and assistance and a way to ask for help and for ideas. So when things did go awry, or you just didn't know what to do, if it's approached that way, then the staff really, they welcome it. Because often when we lose direct care workers, even though obviously pay is a huge issue, but it often, a very common thing that direct care workers will say is that they didn't feel that they were properly supported. So that is one area that there's so much information. If a restraint is used, and in some circumstances, restraints are necessary. Now, if it's happening frequently with no change in behavior, we have a problem on our hands. It's time to go back and look at that plan because it's not working, right? But there are some circumstances where people could be hurting themselves or others, and a restraint is a necessary procedure. We have to make sure that people are obviously trained in how to do it safely. But when there is one, is a clinician going to look at it, and how long after it will they look? And if errors are noted, are they going to share that information with the family? Which again, not approaching it as we're going to catch you doing something wrong, but so we're all, because we're a critical part of the treatment team, right? And we are probably one of the most important pieces of the person served lives. Okay, how does the program address peer aggression? So we're seeing a lot of this because I think that a number of agencies are creating what they call high need houses. And I have to tell you personally, I think for our population, the 4-person group home is quite possibly the worst possible model you could come up with when you have people with challenging behaviors. You do need, obviously, some critical mass for economy of scale and for staffing, keeping your staffing levels and supervision. But when we see programs creating, the behavioral homes, it often just means that you're pretty much guaranteed that every day is a bad day, which is not only bad for the residents, but it's extremely stressful for staff and reducing really high turnover. So this issue, we've had a couple cases where we've done some creative things in terms of getting people protection when someone was hurt or injured by a peer. And I'm actually, this is going to be my last slide, my quote, but I'm going to jump to it now. And I actually have right here the source of the quote, Jen Brown, that asking people whose children, whose loved ones have complex needs to accept less is just wrong. And it happens all the time that families are told things like, well, what do you want to do? Like, who else is going to take them? And your child has problems too. So I think we have to start looking at some other models on how to keep people safe, realizing that it is cost prohibitive, obviously, to just have, standalone one-person houses or apartments without some sort of connection to the greater. Okay. So, sort of the heart and soul of these, this is actually 60 questions all put into 4 minutes. You really just need to get the details. So when someone says, oh, you have trained staff, ask, what does it mean to be trained, right? Because we do have such tremendous turnover. We often have on a Saturday night of a holiday weekend, people coming in that don't really know the individual. So we really want to ask about what the training protocol is, which again, we see often in the under 21 programs, particularly in the intensive ABA schools, but we're not really seeing really robust training programs. This is sort of, you've seen a recurring theme here, making sure that the parents are engaged in all of the process because they have relevant information. And also, too, they need to have the information as well because when you are having your loved one visit, if you're in a residential program, you need to know how it is that they're handling it. When there's changes, how do you share this information with staff and families? Get the system details. This is probably the #1 complaint, not just of families, but from programs and from staff directly, is looking at what is the model so when something changes that everybody knows. And there's so much new technology out there, and the disability community is often couple steps behind the rest of the fields. But we are seeing programs that are looking at innovative ways to share information. And I think treating when there's a shift change more like a medical model, that in the same way that nurses are handing a patient off and saying, you know, he had a stomach ache this morning, he's been asking for juice, but don't give him any more. I mean, those kind of details that you would share with babysitters, right? But often we don't see it shared shift to shift, and it's really important. You know, how families are shared information. When the family is telling something, comes back on a visit, this happened today, you know, just is how I handled it. How do we get it to everyone? And there are programs that are really using technology in order to share it. You know, alerts on staff's phone saying, change to the BIP, okay? And does anybody ever share good news? So we hear this often from people that are residential, that, and obviously even I think in school programs, when you see who that number is, and you're gonna get that call, and you know, I know my heart drops to my feet, and I sweat from, even if it only takes me, you know, half a second, it's still that experience. So if you run a program, if you're in a program, if you're creating a program, make sure that you do this, right? It's so important, and it's not just important for family, so they have a sense of relief, and it's nice to hear. It's also very important for the staff too, because you're celebrating their successes, because the staff really plays a significant role in a person's success. Parental engagement. So again, if you're looking at a program, ask these questions. If you're in a program, if they're not doing it, see if this is something that you can create or consider. And for those of you that are out there thinking and dreaming of creating a program, or you're just a school and you're going to expand it to adult services and residential, we want to see that parents are playing a role in the greater organization. And often, because we do have such limited capacity in residential, we often, though we are, I guess we're a much smaller state than Arkansas, it still can be pretty far, and with short traffic, it could be 5 hours for someone to have to visit their loved one or go to a parent meeting. So why not let parents call into meetings? As simple as that. And I've had clients that have come back and said, you know what, I asked for that, and they said, oh yeah, sure, we never thought of that, right? So, simple question. Does the agency offer opportunities for parents to meet each other, and how new families are connected? So here's a common thing I hear. Someone moves into a group home. The parent says, I would like to meet and talk to the other parents so we can share information. HIPAA, okay? I have a HIPAA slide we'll get to. HIPAA, the most misused provision of law, I think, almost of all time, okay? So you, most of you with individuals with challenging behavior are the legal guardians, right? You're the HIPAA representative, okay? So if I wanted to put on a billboard my son's contact information, we could do it. So a very simple thing is put your information on index cards and just say, can you just give this to the other family member? And just say, hey, call me. Many agencies don't have systems where people connect and don't have, family booklets where families have the contact information, but engage in a little self-help if you don't have that going on. Because we're developing policies, with the new change to fee-for-service, there are so many issues that agencies are confronting. So we want to make sure that families are part of that process. I know that for the rep payee status, there's been a lot of controversy over that. So the rule is an agency cannot insist that they become the rep payee. Now, does that mean you shouldn't do it? No. It's obviously a personal decision, but there are costs to an agency if they're not the rep payee, because they have to bill you and have some administrative costs, but they can't make it a requirement, and there's a lot of misinformation on that. this limit on home visits. Has anybody heard anything about this under fee-for-service? So under fee-for-service, the agency doesn't get paid unless the bed is on the head for the night. Okay?
Head is on the bed.
The head is on the bed, and the bed's on the head. That's when you come home again. Right. And you spend X number, I think it's 4 hours in a day program. So that's a big change in the system. In the old system, it was a contract system, so the agency would be, here's your $160,000, we'll pay you the month before you give the service, and it's done. Not under fee-for-service. Under fee-for-service, the service has to actually be delivered, the provider has to bill it, they have to wait for the money, and if the service, such as residential, isn't delivered, the person isn't in that group home, they're not getting that day rate. Now, that's a big problem for providers. It's a big problem for families that we're working with that are working on creating organizations. When you're trying to do the math of how much is this going to cost, how are we going to run, trying to figure out what is a reasonable vacancy rate, because if someone is not there, even in the day program, they still have to turn the lights on, right? They still have to pay the health insurance of the staff. They actually have to let the staff come in and collect their paycheck if you're not there. So agencies are making policies, and most of them it's happening at a board level. Just make sure that parents are involved in this discussion, but there are hard choices. Now, some states like Pennsylvania, they actually have state-only dollars, so that way there is money available so people can go home more than the allotted number. That is something that you do have to understand the challenges of running a program when it's a new system, and how do you figure your budget out if you're not going to get paid unless someone is there. But it's also very heartbreaking, and I don't know if any of you are any of the Facebook discussion groups, but over the last month it's been a really hot topic where families are accustomed to having their loved one home every weekend, and it's a quality of life issue.
Can I ask a question about that?
Yeah.
So, the head's in the bed, they get the money, but they have the money in the budget. Are the parents asking for Medicaid money when they bring their child home the weekend?
No.
Right. So, why can't they extend that so that the service can be maintained? Because
You mean that the parent gets paid so they have the support?
I can understand if the parent were asking Medicaid to pay them to take that child home, so they can't then pay the agency who's supervising them for the
Right.
majority of the residents' placement. So the state should pay to help maintain that organization who's providing the majority.
Well, maybe that will make our ask list when we're working together, when we break up, but the agency is not getting paid now through our fee-for-service, because we are operating 100% on a matching dollar system now. So if the service isn't delivered, you can't bill for it, they don't get it. The solution could be state-only dollars. So there is a potential solution for it. Okay, fundraising committees. So not to say that, honestly, the existence of fundraising committees are really important, because honestly, if you really want to do this well, you're going to want to spend more and have more than these budgets allow. And even with those big budgets, because the truth is, those numbers were not given to us, to families whose children have challenging behavior, to reward us for all our years of suffering. It's actually what it costs to support an individual with challenging behavior if you're doing it correctly. So I am not in any way saying that having the existence of a fundraising committee is a problem. In fact, when my son was in a private school, it was a really important part of our life. Some of my best friends I know from fundraising events. But you also want to make sure that they're on substantive committees too. So, if there's a human rights committee or a quality control committee or a committee that looks at whether or not, the video monitoring is appropriate. So you want to make sure that parents are engaged in that. Do they do family satisfaction surveys? Which many of them do, but they don't share it with families. So we want to ask that. What's the parents' connection to the board? So are there parents on the board? I mean, honestly, my experience in visiting programs, and last count, I think 17 states looking at programs, that seems to me to be one of the hallmarks of the quality organizations, where families are on the board and are really shaping and monitoring and supporting the organization. So, and what does the board have any way that, you know, they get feedback from families, or families can raise issues? Is there a parent advisory board? This is one thing that a couple families have told me that, yeah, there's a family advisory board, but you have to make a donation to be on it. So that's not really a family advisory board, right? So you want to make sure that families that don't have those resources have access to that. Okay, so this is a new bill that has just gone into effect. It's named after Stephen Kaminas, a young man who died while in the care of a residential program. And this really was a result of parent advocacy. This was a group of parents that asked and asked and asked until finally the legislature and the governor agreed to it. So these are some new safeguards that will be in effect, to go into effect. Unannounced visits, that parents have to be contacted within 2 hours following an injury. Now, again, it's almost unimaginable. Those of you whose children are not in residential, you almost can't believe that would happen, right? But it does. So now we have a law, and providers are all being trained on this now to make sure that they're setting up systems to do that. Some additional testing. Most agencies do drug testing as part of the application process. If the person is someone that could be interviewed, that the parents could be there while their loved one is being interviewed, and that if you do reach the point that they're on the registry. This I want to bring your attention to. This is a brand new unit. It's the Provider Performance and Monitoring Unit. And what that grew out of was that in the old system, everybody had DDD case managers, right? So one of the roles of DDD case management is to not only check on the person, but to look at the quality of services. In our new system, we have support coordinators, which are helping you navigate the system, get your budget up, in theory, help you identify services, but that's a topic of another night. But since we don't have that anymore, DDD created this new unit, and that is a resource that if there is a problem with the provider, that this is someone that can be contacted, and each agency has someone assigned to it, so that way they can see if there's a pattern that, wait a second, everyone is talking about the same issue about no change in the behavior plan for 3 years or something like that. So she actually just spoke at our statewide meeting, and I have to say, I really give her credit, because that, a few of you were there, that was a tough crowd. Over, I think, 100 families came, and it was sort of one story after another. This happened, or I was told this, or they said we can't do that. And she was so candid in terms of, we're new, we need to do 10 things, we're only doing one. I do have to really applaud the DDD for creating this unit, and also too for really just the honesty in terms of what they have to do.
Just a note from the field on the Provider Performance and Monitoring Unit. I have a case where we had to call them in for some untruths that were told to the family and to me from the agency side,
Right.
relating to medication and medication administration and some outrageous requirements on prescriptions and
Right,
things
right.
like that, and they got right in there
Yeah,
and they turned it around really quick.
right.
So I was really impressed.
So, I mean, we've had for years, hotlines that you can call. Some agencies have internal hotlines, but we've never really had a unit that has, really been a point for families. So we're very encouraged about this. Okay, so what are the sort of most important takeaways of this, right? So what are we looking for? Some really simple things that are gonna welcome you and connect to and inform you, right? If we don't see those mechanisms, which obviously some of my questions, if you're asking them, you're gonna see whether or not this exists. The other important thing is that the role of clinicians. So, not that there's anything wrong with accountants or development departments or public relations, although my issue is always, you don't really need public relations, because if you build it, they'll come, right? But, Some of the bigger agencies do have that, but what is the role of the clinician? The clinician has got to drive the project. The clinician's concerns have to be really what informs decision-making within the agency. And the role of families, which we've, talked about. And once again, whose HIPAA rights are they? So when you hear HIPAA, feel free to call us and we'll tell you whether or not HIPAA applies or not. Okay, so I touched on this a little bit. So are the D's and the E's going to float the A's? Because it is not an exact dollar for dollar. So the agency doesn't have to show like, look, I paid this much to the OT and used up that much money, particularly in residential, because there is, a day rate for individual supports. So in some ways, the system was designed that way, and it also works in the other way, that if someone has a smaller budget, but something happens that their needs increase, it's the agency's responsibility to push in more services. Again, being sympathetic to not only agencies exist, but agencies that are trying to or deciding whether or not to do this. Many schools are now looking at the issue. Should we go into adult services? Many parents, small foundations are working on projects. So it is, it is a challenge, particularly if you're going to serve, a broad spectrum. But from your own personal perspective, to advocate for your child, if your child has complex needs and challenging behaviors, you want to make sure that there is a very specific written plan. You want to detail the services and very specific with goals. So not just he'll be successful in the community, but he's going to go fill a soda cup independently. And you know what? If he needs 2-on-1 staff when he does that because he's got an issue with aggression or self-injury or elopement, that needs to be in your plan. This is something that we learned about, that access to the community is, you want to make sure that's clearly outlined in your plan, and you can always also, you don't have to wait for the annual meeting, you can call IDT meetings at any time, which is an interdisciplinary team meeting, so you're looking at this. Again, some agencies are excellent at this. They will actually give you a monthly report and let you know, this is where they went, this is what they did, this is how many times they've gone out. This we learned about where an agency was actually charging extra for the person to go out. So they were saying, oh, well, Saturdays the staffing ratio is down. If you want to get to the swim class, we have this other entity that you can purchase it, right? You see someone shaking their heads, they're aware of that. That is not allowed, okay? So watch for that, and that is really problematic. Yes?
Lisa, if there's a plan to go out in the community, so if a calendar of activities is made, and, these are the plans, on this night they're supposed to do this, on that night they're supposed to do that, but then you're told we couldn't do it, we were understaffed. And like, we've heard that a lot, well, we couldn't do it, we were understaffed.
Well, if you're in a group home, your child is on a community care waiver, okay? And as we go through the process of SDPs and programs are reviewed, access to the community is one of the criteria for whether or not a program should continue or not. Now, does it mean that every night on the calendar, staffing shortages are obviously a problem. What we pay direct care workers is a terrible problem. We have to figure out other solutions, other models, private philanthropic partnerships to make, it more of a, an actual career path for people. But if it is rampant and someone is not getting out consistently, then you have to raise it, and you could call Wendy's unit to talk about that. They do look at that issue on whether or not people are getting out to the community. Okay, so this is another exciting thing to tell you about. This was just 2 weeks ago. So have people heard about the COA funds? Okay, so some yes. Okay, so municipalities have housing funds, and this is going for decades on Mount Laurel decision that essentially gave fair share housing, affordable housing obligations to towns. And many towns in New Jersey were notorious for never, ever building anything. and the money just sort of stacked up. And in some circumstances, if they built new development, they could actually pay like a fine almost into the pot, so the money has accumulated. There's been a series of decisions that have said no more, okay? These are the numbers. Well, this just was about 2 weeks ago. There were 2 towns that were fighting the issue of how they calculate how many units they're shy, and the towns lost. And Fair Share Housing, which is a not-for-profit law firm, won the case. And so now there is a lot of pressure on towns that they're gonna have to use these affordable housing dollars. And, you know, it's just, I think it's one of the bright spots out there. Now, we as a community, we have to make sure that these dollars are used for our population. There are obviously many people with great needs, right? Low-income families, homelessness, mental health. And, you know, if I take a step back, I can make the case for each one of them, but given my own, not only personal interest, but our role in our firm, we are strongly advocating to make sure that people with disabilities are you know, getting a fair share of this, because our guys are low income, right? In fact, I know my own son, who is a EA, is negative income, okay?
What was the acronym that you used?
COA, so Council of Affordable Housing. So I said this earlier, that if a person's needs are complex, it's unacceptable to ask families to accept less. We hear this a lot where providers are saying, well, what are you gonna do? You know, who else will take your child? I think that is changing with these new budgets. And I think that with the new rules over community care, agencies are gonna have to figure out how to allow people to access the community and be successful. And it's the answer of we're too short staffed, or it's too hard, or the behaviors are impeding. There really is an affirmative obligation that people are getting access to the community.
Isn't it true that with the switch to Medicaid that there will be more dollars to pay the direct care workers and the level of staff can
Well,
go up?
they-
Or is that a rumor?
Okay, so no, the rates for acute cases have gone up significantly, but there's no directive to the agency that that's what they have to pay. In fact, we've heard a lot of families that are in the self-hire situation, where they have individuals that are currently working, they're using their budgets, they're getting paid $15 an hour, and when fee-for-service kicks in, suddenly that agency is gonna get $46 an hour instead of $25 an hour. Making sure that it goes to the direct care workers is really important. So for the acute cases, again, be engaged, be involved, make sure that you're bringing, you know, everyone together collectively. This population, and this is when we're now gonna get to, I think, the heart of tonight, we're gonna actually go into the room and break up into groups, is that on the national level, I think one of the explanations on why New Jersey had such a horrible statewide transition plan, literally, I was at a meeting, a national meeting in Chicago when our plan first came out, and everyone was reporting from the states, and the moderator was standing up on the stage and said, okay, so now we're gonna hear from the states. Oh, I see Lisa Parles is here. You're the worst state in the country, so why don't you go first, okay? Well, we came back, and we created the Say No to the NJSTP, which after we got a good one, we changed it to New Jersey Citizens for Choice in DDD Housing and Services, which is a Facebook page. And hopefully we have this somewhere on here, but if not, we'll say it again. That really what happened, I think, is that the voices of self-advocates were very, very strong, and not that they don't have an important role to play in policy, but people with challenging behaviors and complex medical needs really were not at the table. And so a lot of the proposed rules, in fact, New Jersey's STP that said no more than 25% of any kind of complex housing could be disabled people, they actually proposed that at the federal level, and it got crushed, right? Just think about that. What other population would it be okay to say, oh, there's 100 units. Oh, you're number 26, you have a disability, it's too many of you, right? We wouldn't say too many women, too many African Americans, too many Jewish people, right? We just would not allow it. I mean, I really do think that the underlying premise is discriminatory. So we need to collectively be talking about what our needs are. And I know it's really, really hard. I mean, I had 7 different families reach out to me today that they so desperately wanted to come, and really, bright, engaged families that have wonderful ideas. They couldn't get here. It's too hard. And we see the same thing in the medically fragile population, that people can't get the help in the home. They're literally afraid that their child will die if they leave them. So we have not really been represented absolutely at the national level. These 2 groups, the Coalition for Community Choice and Together for Choice, are doing an excellent job at making our voices heard, but we need to also, in New Jersey level, make sure that we're doing that. So when we were at the statewide meeting, okay, so is anybody a member of the Family Support Council? Does anyone know about it? Okay, I have one. Okay, so we have in New Jersey Family Support Councils. It's divvied up by region. Urban, I think it's 1, maybe region 1. So they're great organizations. They hold usually monthly meetings, and they also come together for these quarterly statewide meetings. So we did the last 2 that they did. I guess 4 months ago, we did one on meeting the needs of individuals with complex needs and behavioral. I did this presentation. Suzanne Buchanan did the basics of what an FBA is and what ABA is. We had someone from the medically fragile community, and it was a very intense meeting. There were over 100 families there that were really talking about how their needs are not getting met. We don't have a lot of options in New Jersey. When you go on that Madison House Foundation, there's some really exciting stuff going on. We need to absolutely bring it to New Jersey. Then last month's statewide meeting was when Wendy Yasko came to speak, and someone from Children's System of Care, which is under 21, and everyone was telling the stories, and one of the persons from the state said, if you see something, say something, okay? Which, that's a very good concept, right? We use it in all sorts of things. And the state chair, Paul Bostine, he stands up and he says, I absolutely agree that when we see something, we'll say something. But we've now just spent, 4 hours together, and you have heard all these stories. So what we say to you is, if you hear something, do something. And that really has to be our rally cry for this population, is that we have to make sure that the policymakers, we have new administration, that they know that this population's needs are not being met. And a whole nother world in thinking about when they become members of the aging population, that we really literally have almost nothing in New Jersey to address those needs. So that's our cry here, that if they hear something, we're going to ask them to do something. So that's why we're actually going to do what we're going to do next, and I did good timing wise. We're going to go into the other room, and my 2 colleagues from my law practice are here. We have both Denise and Judy are going to lead groups as well. We're going to split into groups of 3, and what we want to do is we want each group to come away with, I said 2, but we're going to make it 3. 3 asks, okay? 3 things that you think we need in New Jersey for this population. So, and we've been doing this around the state and in a couple different forums, and we're going to bring it to the policymakers. Because honestly, I mean, in my view, the 4-person standalone group home just does not make sense for this population. We need to look at what other states are doing with clusters, and how about farmsteads, right? Do you know we do have one farm program in New Jersey? It's private pay. Okay, that's a problem. It's a fabulous, wonderful, wonderful program, but we can't let it be. Oasis, it's a wonderful program, but the residential portion is private pay. So there is movement at that federal level, okay? Farm communities are getting approved in other states, so it is an option now. So we need to go out and ask for it and create it and get together and build new programs. So with that, and I actually did it in 57 minutes, let's go move into the room where there's small